This module is radiation protection. So this is going to discuss how to protect the patient and yourself as the operator. We learned in radiation biology module that X radiation can cause biological changes to all of our cells if not protected. So this is the section that is very important so that you can understand how to keep your patients safe. And we're going to start here with our patient protection. And there are ways that we can protect our patients before, during, and after exposure. So this is all about what to do before exposure. You want to make sure that the doctor has prescribed the radiograph. This is something that's usually discussed in the morning meeting, or it's a standard. Your patient comes in every 6 months, they get their cavity detection x-rays taken, or once a year they get those cavity detection x-rays taken. But you need to make sure the doctor is aware that this x-ray is going to be taken. Or rather, the doctor should be the one making you aware that this x-ray is going to be taken. And keep in mind that different conditions have different needs. So you may have an emergency patient on the schedule, but it doesn't necessarily mean that they are required to have an x-ray. There are some things that the doctor can see clinically without having that exposure to radiation. So this is where it's important. Make sure the doctor has prescribed that radiograph. Also, you need to be aware of what that patient is there for as well. So, for example, a panoramic radiograph is used to check for wisdom teeth, and a periapical is used to check for an abscess. So if that patient is there with symptoms that are consistent with wisdom teeth erupting, and you take a PA, we may not find the answers that we're looking for in that PA. So then a panoramic is going to need to be taken anyway. So now that patient has been exposed to an unnecessary radiation from a PA. The second thing is use of proper equipment. You may not be responsible for making sure that the equipment is proper, but you may be the one responsible for making sure that the technicians are scheduled to come and check the equipment. So, with that, the use of proper equipment includes proper tube head filtration and will also include proper collimation. And it will also have your position indicating device or your PID. Which one are you using? Let's talk a little bit further about filtration. So within that tube head, there are two methods or two types of filtration. The first is called inherent filtration, and this is when that primary beam of radiation is going to pass through the glass window, through the insulating oil, and through the tube head seal. This type of filtration is placed by the manufacturer, and it is going to be equivalent to 0.5 to 1 millimeters of aluminum. However, this does not meet the state and federal minimums, so we must have more filtration. We have to add in that second type of filtration, and that is called added filtration. And these are the aluminum discs that are out. These are the aluminum discs that are added to filter out the longer, low energy X-rays. Remember that these longer, low energy X-rays are more harmful to the patient, so we want to be able to block them out. That aluminum disc is placed between the lead collimator and the tube head seal. So remember that primary beam passes through the glass window, through the insulating oil, the tube head seal, and then it hits that aluminum disc to filter out those X-rays. It's added in 0.5 millimeter increments, and these two types combined are known as total filtration. For any X-ray machine that operates at 70 kVp or higher, it requires the use of 2.5 millimeter. It requires the use of 2.5 millimeters of aluminum filtration. Collimation is another step in patient protection, and this also happens before. This is also inside the machine. And collimation or the collimator restricts the size of the beam. So it's going to reduce the size of the beam that will actually come into contact with the tissues. It is available in two shapes. One is rectangular, and it makes the beam about the size of a size 2 film. And the other is circular, which makes the beam cone-shaped and about 2.75 inches. And the 2.75 inches, that's the federal regulation. It has to be at least that small. So to be in compliance, the collimation needs to be no bigger than 2.75 inches. And that is still slightly larger than a size 2 film. So you can see here, this is your circle one, or your cylinder, as it's called here on this photo. Let's try it again with that drawing of the circle here. Okay, so as you can see here, where I'm drawing this red attempt at a circle, that is your collimator. So that is 2.75 inches. And then here in this somewhat of a square is your film, or rectangle rather, is your film. So all of this green area in between here, that's showing that that is your patient's skin that is going to be exposed or going to be irradiated. With the rectangular collimator, here is the collimator. And again, here is your film or your receptor. And all of that green, purpley color in between here, that is the area that is going to be radiated. So you can see the difference in the amount of skin or the amount of tissue that is going to be shown or going to be irradiated. So the rectangular collimator is going to be better, but that's not necessarily up to you. It's when, the manufacturers make the machine, what they determine is best for their machine. And then before exposure, we also have the PID, or the position indicating device. And this is available in 3 basic shapes. And we have the cone. And the cone is no longer used because of the scatter radiation that it produced. And don't get this confused with the general term of cone used for the PID. This is the conical shape. So think of it kind of like a megaphone. You know what the shape of a megaphone looks like, but it's no longer used because of the scatter radiation it produced. The next one is the rectangular. This is the most effective in reducing patient exposure. Same as the collimator. Think of the way the film is shaped. The film is shaped like a rectangle. So this is going to be the most effective. And then you have the round, which is available in the 16-inch or the 8-inch. And the rectangular is also available in the 16-inch or the 8-inch as well. Now we can move on to our patient protection during exposure. One of the very first steps you can take during exposure to protect that patient is to place them with the thyroid collar around the neck. By doing this, you are going to protect the patient from having radiation reach the gland that protects the thyroid. And that thyroid collar, it may be separate or it may be attached. So there are some where you will have 2 separate pieces that you will need to place on the patient, and there are some where they are connected. And what it is recommended for is use in all intraoral films. Sometimes with those extraoral films, that thyroid collar could get in the way. So it's not typically recommended for extraoral films. And then the piece that the thyroid collar will be attached to, if it is attached, is the lead apron. This is recommended for all films. It doesn't matter if it's intraoral or extraoral. It is recommended for all films. It has 0.25 millimeters thickness of lead and will cover the lap and the chest. In many states, this is a mandate, meaning you must use lead aprons on all patients. And now they actually do make some lead aprons that are lead free. They're made of a different type of alloy that protects the same way as lead, and they are 30% lighter. Some of your patients will say how heavy that the lead apron is. Some patients like it because they feel like it's a little bit of a security to them. But these alloy or lead-free aprons are 30% lighter. Just to give you an idea, if you've never seen a lead apron before, this is a picture of one with the thyroid collar attached and one without the thyroid collar attached. Continuing on with our during exposure protection, the next thing is your image receptor. Digital receptors are going to require less radiation, so this is the most effective method. But of course, this is something that you can't really control so much if your doctor doesn't have digital radiation yet. They don't have that capability. But if you do use your digital radiation, and when using the traditional films, it's always going to require the fastest film speed in order to give the least dosage of radiation. And then we have the beam alignment device. This is going to help stabilize the receptor in the patient's mouth and reduces the chance of movement, which means the film won't need to be retaken. So the beam alignment device is just something that's going to hold the film. That way you or the patient does not have to hold the film in their mouth. And we know it's going to be a little bit more secure. And then during exposure still, we have the exposure factor selection. So this is adjusting your KVP or your KV and your MA for each patient. Understanding what those buttons do and what those functions are for and how to adjust them to be appropriate for that patient. Mostly now these are preset, so all you have to do is press the button rather than adjusting the dials like the old machines. But you need to know and understand which buttons to press so that you're adjusting the KVP and the MA appropriately. And that brings us to proper technique. Any retake must be avoided. Any unnecessary retake is an extra exposure to radiation. So we need to avoid those as best as we can, which means we need to understand all techniques. And what we mean by techniques here are things such as the paralleling technique, the bisecting technique, the bite wing technique, so on and so forth that we will discuss further on in the modules. And no matter what technique you're using, it definitely helps if you have a sequence to take the images. Know where you started, know what images you've already taken so you're not taking the same image twice and leaving one out. So that finishes how to protect the patient during exposure. But what about after exposure? That can start with proper handling of the receptor. Keep in mind that any type of artifact can cause damage, especially if you're using a traditional film. So your fingernail, a paper clip, any writing utensil that you may use to write on the film, all of that can damage the film, resulting in a retake being necessary. This isn't quite an issue when we're using digital because there's no film typically to use. It just goes from the patient's mouth directly to the computer. So we kind of eliminate that step when we're using digital. And also, again, more geared towards traditional film, don't set it in water or drop it on the floor which may mean you need to do a retake. Dropping it on the floor, especially if you've already taken it out of the envelope, could cause scratches. Those little microscopic pieces of dust can scratch the film. That's going to require a retake. And then making sure that we use proper film processing, or if it is digital, proper image retrieval. Improper film processing, of course, can make the film non-diagnostic and require a retake. Or image retrieval. If you are using the type of digital x-ray that requires you to do an extra step to retrieve it, you could delete the film or delete the image, which would mean you'd have to retake it because now it no longer exists. And now we have our operator protection. So these are the things that you need to do to keep yourself safe. And there's a couple guidelines that we can follow. And the most basic one is avoid the primary beam. Avoid that tube head. Stay as far away from it as you can. That way you are not in contact with that primary beam. And this can be achieved with distance and position. So whenever it's possible, you always want to leave the room or stand behind some kind of lead barrier. However, if you cannot, you need to stand at least 6 feet away from the tube head. 6 feet is the distance they have determined that makes you safer, so at least 6 feet away from the tube head. And this is based on the inverse square law, where the beam loses power as the distance increases. So if you are 6 feet away, that is 6 more feet that that beam would have to go, which is 6 more feet worth of energy that the beam will lose. And or stand 90 to 35 and stand 90 to 135 degrees from the beam. That beam, even though there may be some scatter radiation, that primary beam is not going to change its trajectory. It's not going to change the pattern in which it's traveling. It will always be a straight line. So if you are standing 90 to 135 degrees from that beam, you should be safe. And you should never hold the receptor in the patient's mouth. You are putting yourself in the direct line of fire if you are holding it in that patient's mouth. And you should also never hold the tube head to stabilize it. You want to make sure that tube head is as stabilized as possible before moving away from it so that you can press the button. Another way operators can protect themselves is with shielding. So again, if possible, stand behind some sort of protective barrier. And most offices will incorporate this into the walls within the thickness of the drywall. Some offices will actually use a lead glass window or a mirror so that they can still see what's going on inside and monitor the exposure. And lastly, we have radiation monitoring. There's equipment monitoring where your machines should be monitored for leakage There's equipment monitoring where machines should be monitored for leakage radiation. This is something that is done with the techs. So you would need to call for technical assistance at whatever company or whatever organization monitors your equipment and have that scheduled. And what it's checking for is radiation that exits from the tube head that isn't the primary beam. So for example, if the X-ray tube head has a leaky tube head seal, radiation can leak outside of that tube head seal. Therefore, that would be radiation that is not a part of the primary beam that is exiting the tube head. There's also a device that you can get through your state health department or the manufacturer, and it's also going to monitor your equipment for leakage radiation. There's also personnel monitoring, and this is using a film badge or something called a dosimeter badge to monitor any radiation that you may be exposed to as the operator. These badges need to be worn at a specific level. It's either the chest or the waist. It depends on the type of badge you have and what that manufacturer dictates. So just make sure you're paying attention to where it tells you to wear that badge. Otherwise, it might not monitor you correctly. And that badge is also worn for a specific period of time, and then it's sent back to the company. The company will evaluate the badge and then send a report to the office telling you who got exposed and potentially how much exposure and to where they were exposed. And it's important to pay attention that if you are the dental personnel or the person who works in the office and you are having your teeth cleaned for the day, so you're getting x-rays taken or something, make sure you take it off. It should never be worn when you are exposed to the radiation as a patient. In order to establish some guidelines to help keep patients safe, there has been some radiation safety legislation. The first one of note is at the federal level, and it is the Radiation Control for Health and Safety Act and was enacted in 1968 to standardize equipment. So now basically all radiology equipment is very similar, especially the inside of the components. That way, if something's wrong, it's a little bit easier to kind of understand, and you can kind of have any technician that understands the basic concept or understands how these machines work can come and fix it. And the second one is also at the federal level, and it is the Consumer Patient Radiation Health and Safety Act. And it was enacted in 1981 to fix issues related to education and certification of people using the equipment. This is the act that created requirements for the accreditation of any education program that trains people who are going to be taking radiographs. So, accreditation means you get the okay or you get the approval to be a school. So, this act kind of put into action the standards that a school must meet in order to teach radiation. There are other factors, though, with legislation that can vary from state to state. So be mindful of what state you're in and understand the laws that apply to you when it comes to dental radiography. And the last thing here with radiation protection is the maximum permissible dose. And what that is the maximum dose equivalent that a body can receive in a specific period of time, or how much can the body endure with little or no injury. And there's some limits here. So for an occupationally exposed individual, which would be a dental assistant or anybody in the dental office, that is 5.0 rems per year. Now, if you are an occupationally exposed and pregnant, that drops down to 0.1 rems per year, which is the same as a non-occupationally exposed person. So your patients that come in, they are non-occupationally exposed and they should only receive 0.1 rems of radiation per year. And radiation protection can basically be summed up in one simple thing, and that's the ALARA concept. And this is the concept that all exposure to radiation is kept to a minimum, and we summarize that with the ALARA concept, which stands for as low as reasonably achievable. And as long as you can remember that, you will always have a good baseline for radiation protection. So question number 1 for our review. Which of the following describes the use of a filter in a dental X-ray tube head? A, it reduces the size and shape of the beam. B, it removes low energy waves. C, it removes the dose of radiation to the thyroid gland. Or D, it decreases the mean energy of the beam. And the correct answer is B. It removes the low energy waves, which are harmful to the patient. 2. Which of the following position indicating devices is the most effective in reducing patient exposure? A. Conical PID, B. Round PID, C. Rectangular PID, or D. They are all equally effective in reducing patient exposure. The correct answer is C. The rectangular PID is more effective at reducing patient exposure to radiation. 3. Which material is used as a collimator? A. A lead plate, B. Aluminum plate, C. Copper plate, or D. Tungsten plate? The correct answer is A. A lead plate. And last review, which is not a component of inherent filtration? A. Oil, B. Unleaded glass window, C. A leaded cone, or D. Tube head seal? Correct answer, C. A leaded cone.